Medurstand. Understanding Medicine.
I am Professor Aziz-ur-Rehman, and this is the third in the series of lectures on congenital heart diseases. In the first lecture, we discussed some basic concepts, introduction, and classification of various congenital heart diseases. And in the second lecture, we discussed common features which characterize three left to right shunts, ASD, VSD, and PDA. And today we are going to discuss in detail the first of these three conditions, atrial septal defect. I very strongly recommend that if you have not attended the second video, which describes the features or the common features of left to right shunts, I think you must watch that video before you watch this one. Only then you will understand it better. Now, atrial septal defect, the name is self-explanatory, and normally the foramen ovale, which is present in the fetus to allow fetal circulation going from the right to the left, which is required in that situation, that closes at the time of birth. Now, sometimes that might not close, or there is some additional defect close to the normal foramen ovale. So that condition would be called atrial septal defect. That means defect in the atrial septum. Uh, this is the picture, and this, of course, we do not want our patient to go to this stage, and this X-ray is typical X-ray of pulmonary hypertension. Those who know reading these X-rays, you can appreciate cardiomegaly, and this must be because of the right ventricular hypertrophy. And you must also appreciate this prominent pulmonary conus. This is due to pulmonary hypertension. And you may also appreciate this increased shadowing in the lungs, which may be due to increased pulmonary circulation, which is the feature of this disease. Now, this is patient, I think, with advanced pulmonary hypertension as a result of atrial septal defect. Now, this is the diagram showing that this is the intra-atrial septum, and if there is abnormal communication, blood could actually theoretically flow either way. It could come from the left to the right, or it go from the right to the left. But as we all know, that the pressure in the left atrium is higher, so the blood will always flow from the left to right. So that is why atrial septal defect is one of the types of one of the condition where there is left to right shunt. Uh, there are some types. I think first of all, the defect could be anywhere. If it is in the upper part, and this picture actually does not show, I think if you imagine this may be pulmonary vein and this may be the systemic vein, if there is abnormal communication between two atria in the upper part, it could affect the septum as well as the veins, and that is called sinus venosus. But the commonest type of atrial septal defect is when the defect is somewhere in the middle, in the region of foramen ovale, and that is called a secundum defect. Why do we call them secundum? Believe you me, I don't know, but this is called secundum. Secundum is the commonest type of atrial septal defect which we see in adults. Then the third may be in the lower part, and the lower part is called primum, and this is more serious because when this part of the septum is defective, it would cause some structural abnormality of these cusps also, which are attached to this part. So because of additional cusp abnormality and also the possibility of the defect in the upper part of the interventricular septum, so the primum defect is very, very serious. So primum and venosus are less common. Secundum, which is present in the middle part, is more common. But minus those features which are caused by the additional abnormality, the clinical features of all three would be more or less same. Now, physical findings, I think very important to know. First thing is right ventricular hypertrophy. I think let me explain why people with atrial septal defect develop right ventricular hypertrophy. One factor which can cause hypertrophy is volume overload. What do we mean by volume overload? If a ventricular chamber, in this case right ventricle, if it receives more blood during diastole, so it will fill more. If it will fill more, it will contract with more force, and that will ultimately lead to hypertrophy. So, how do we get increased venous return or increased volume overload in atrial septal defect? Because in this case, right ventricle is receiving blood from the peripheries, from the superior inferior vena cava through the right atrium. Normal blood which is coming from the body is coming to the right ventricle. So that is the normal share of right ventricular volume, the venous return. But some additional blood is coming from the left atrium, which was actually supposed to go to the left ventricle and onward. From the left atrium, it comes back to the right atrium, and during diastole, because blood from the right atrium comes to the right ventricle during diastole. So during diastole, more blood comes to the right ventricle, some from the systemic circulation, some from the left atrium through the patent duct, through the defect, atrial septal defect. So that is why right ventricle is getting more venous return. That is why right ventricle would be dilated. That is why right ventricle would contract with greater force and ultimately will hypertrophy. So this hypertrophy can be clinically detectable by the presence of left sternal heave. Left sternal heave means this area, left is this part. This is where the right heart is. So there will be left sternal heave because there is a right ventricular hypertrophy. Other features of right ventricular hypertrophy on ECG, on X-ray will also be present, and of course on echo there will be definite right ventricular hypertrophy. And then this interesting finding of I think there would be wide and fixed splitting of second heart sounds. Again, I will have to explain to you how this happens. Do you know that normally our first and second sound both have actually two components? In the first sound, it is usually not possible to appreciate two components separately, but in the second sound consists of pulmonary component and aortic component. It is caused by the closure of aortic and pulmonary valves. So there is aortic component first and then the pulmonary component second. Okay, so the second sound consists of two components, aortic first and pulmonary second. Now, what happens when we take a deep breath in a normal person? So, when we take a deep breath, there is like this, the pressure in the lungs, pressure in the chest becomes negative. That means more blood is sucked into the lungs. So there is more blood coming to the right side. At the same time, because of increased lung volume, less blood is going to the left ventricle, left side. So there is more disparity. The closure of pulmonary valve is further delayed and the aortic component comes even earlier than its time. So that is why we have the splitting gets widened during inspiration. That is a normal phenomenon. But in these patients, since the right-sided venous return is already more than the usual, then there is wide splitting of the second sound. Now, once we take a deep inspiration, then further splitting does not occur. Why? Because of the communication between the two sides and the pressure differential does not develop. The pressure on the right and left side equalizes because there is a foramen inside. There is a communication. So I think if you have not understood this well, then just remember that in atrial septal defect, we have wide and fixed splitting of second heart sound. And the third feature is a presence of ejection systolic murmur, and this murmur is actually a functional murmur. The defect itself, the atrial septal defect itself, does not cause any murmur because the pressure gradient is minimal and the pressure flow from the left atrium to the right atrium does not cause too much of turbulence and does not produce a noise which could result in a murmur. But right ventricle is creating more stroke volume, and because of that there is would be a functional murmur arising from the pulmonary valve. So there would be a pulmonary systolic ejection murmur best heard on the pulmonary area. So these three clinical features, they characterize this atrial septal defect. These days, actually, we are lucky to have these echo available. Echo is absolutely a great test in any congenital heart disease, in any rheumatic heart disease. We tend to do an echo, and echo actually tells us everything. So even if you miss these findings, or if you are unable to pick up these findings clinically, uh, perhaps diagnosis will be made by echo, but you should at least be able to pick up something. For example, right ventricular hypertrophy is easy to pick, or at least you could see that the precordium is unusually dynamic. And if you are unable to pick up this wide fixed splitting, you should be able to pick up this systolic ejection murmur. So if that is the case, suspect congenital heart disease and have the appropriate test. You could have X-ray, you could have ECG. They will also give you useful information, but best test in this setting is echocardiography. Now this is the graphic diagram, the picture of this murmur. There is a murmur which is heard on pulmonary area, and this pulmonary area is second intercostal space right to the sternum. This pulmonary area, there is a systolic ejection murmur, and this is actually a systolic ejection murmur. And you know, a systolic ejection murmur is this diamond shape. It starts some milliseconds after the first sound, so and then it increases in intensity, reaches its intensity in the middle of the systole, then it decreases in intensity. This is called systolic ejection murmur. This is also called a diamond shaped murmur, or this may also be called crescendo decrescendo murmur. This is a funny name, but the crescendo is something which increases and decrescendo is something which decreases. Since this murmur increases first and then decreases within this systole, this is called crescendo decrescendo murmur. You would have similar murmur in aortic stenosis also, but that murmur will be best heard on the aortic area, not in the pulmonary area. Plus, it would have some systemic sign in pulse and in blood pressure. So this is the murmur of atrial septal defect. Then what is the treatment? Treatment is recommended if pulmonary circulation exceeds the systemic circulation by 2 times. A minimum. I told you that in all left to right shunts, systemic circulation, the pulmonary circulation is more than the systemic circulation. If it is 2 times more than the systemic circulation, even if the child is asymptomatic, it is best to operate. Of course, the ultimate decision will be based by a competent cardiologist and a cardiac surgeon, and also by the family, but this is the criteria. You should not delay it for too long, because in that case pulmonary hypertension will develop and then operation or the treatment will not be possible. And very painfully, there is actually no medical treatment. There's nothing in the form of, though we give some diuretic things like that, but there's nothing no medicine which actually really helps. Then what is the treatment? This is the implantar septal occluder if the child is lucky, or the surgery. Now let me show what is this occluder. This is done non-invasive. Not actually, no, the chest is not open. It is done through a catheter. Now this is the picture. Suppose this is the defect. Now the child would be considered a suitable candidate if it is the secundum type of defect, so that on both sides of the septum there is some septum where this device can be deployed. Now this is the shape of the occluder. It would be actually, when passed, it will be like it will be compressed, and once deployed it will take this shape. Now this is the picture I've drawn. This is, suppose this part is the defect, and this disc will be placed in such a way that one will be on the left side, the other part on the right side, and this would occlude the defect. So nice. Just with catheter you can block this abnormal communication. Of course, it requires highly trained personnel and a proper setup. We unfortunately do not have these facilities everywhere, but some centers in Pakistan, they are offering this. So I think if we have a case, we must refer the case to the proper setup. Now, those who have primum defect or sinus venosus, or where the secundum defect, there's a very big one and there's not enough intact septum where it could be deployed, they would require open heart surgery. So that was it. I think this was a brief account of atrial septal defect, and in my next lecture I will take up ventricular septal defect. I am really looking forward to see you there. This was Professor Aziz-ur-Rehman from Medurstand. Thank you.